Good morning, you all. I am Lieutenant Commander DLL Kamnathilaka. It's a great pleasure to address you all in this symposium and talk to you all about safe diving. Under safe diving, I will talk here about barotrauma in divers. Why did I choose this topic to talk to you about? The reason is, as shown in the image, there are about 200 diving fatalities occur worldwide. Out of those fatalities, 1 in 4 caused by arterial gas embolism, which is a result from pulmonary barotrauma. So this shows the magnitude of importance of why divers must learn about this. There are so many barotraumas can happen in divers. For example, pulmonary barotrauma, ear barotrauma, sinus barotrauma, face mask barotrauma. Due to the time limitation, I will discuss here only pulmonary barotrauma and little bit about ear barotraumas. How this barotrauma happens. To get to know about the pathophysiology, you should know about some physics. Out of the laws, Boyle's law is important here. It says at constant temperature, volume varies inversely proportional to pressure. This animation will give you a clear understanding about this law. When you're putting a gas cylinder deep at seabed and fill the balloon, it has a fixed volume of air at certain pressure. But when the balloon is reaching the surface due to low ambient pressure, the volume will expand. So that is because of the Boyle's law. So there are few elements needed to produce barotrauma: membrane line space, ambient pressure change, rigid walls, gas filled space, and an enclosed space. If a rigid gas filled space properly vented, barotrauma will not occur. Here I will give you a real case scenario to get you to understand better how barotrauma occur in a diver. Jasita was a relatively inexperienced diver, 19-year-old, and in good health. He was performing a free ascent from 10 meters. On reaching the surface, he gave a gasp, his eyes rolled upward, and then he floated motionlessly. While he was being rescued from the water, it was noted that blood and mucus were coming from his mouth and he was unconscious. Resuscitation was commenced immediately using oxygen. He was noted to be groaning at this time, but soon after appeared dead. Resuscitation was continued while he was rushed to the nearest recompression chamber. 30 minutes after the dive, he was compressed to 50 meters but with no response. Autopsy verified the presence of pulmonary barotrauma. The diagnosis is air embolism resulting from pulmonary barotrauma of ascent. Next slide, I will show you a real footage of such incident. Here you can see two persons doing free diving here, probably from a cruise ship. The first man was panicked and shoot to the surface without exhaling. This is a very high risk behavior. He could develop barotrauma. It is important to come to the surface slowly and exhale while doing that. The second man is doing pretty well. He's exhaling and he's coming to the surface very slowly. Then you can see alveoli, the volume of air at the seabed, it is very low, but when it comes to the surface, volume will rise. So this can lead to rupture of alveoli and release of air into the adjacent tissue. Again, you can see the first person is shoot to the surface without exhaling. So Pulmonary barotrauma, also known as pulmonary overinflation syndrome. Here, what happened? Expansion of gas trapped in lung during ascent due to rupture of lung tissue. This is caused, as you've seen in the previous footage, breath holding during ascent, rapid uncontrolled ascent, and conditions where air trapped in lung can also give rise to the same condition. So, what are the conditions which can cause air trapped inside the lung? Asthma, it can be due to thick secretions, sarcoidosis, cysts, blips, and spontaneous pneumothorax. So these are high risk conditions which can develop barotrauma. So during medical evaluation of divers, we check above condition and exclude them from diving. So arterial gas embolism is the most critical condition which can arise in pulmonary barotrauma. So here, alveolar rupture with concomitant venous or capillary rupture lead to air release from alveolar. Air travels through pulmonary vein to left heart, then emboli pump out to the systemic circulation and distribute to all over. So here, central nervous system and heart are the most susceptible places. Stroke commonly caused by emboli to the brain. If the emboli goes to coronary artery, it will lead to myocardial infarction. So usually these patients present within first 10 minutes after surface to the after surfacing. Here you can see bubbles travel through left heart to the systemic circulation and to the brain. Here I will here it mention the presenting signs and symptoms of arterial gas embolism. They can present with stupor confusion, coma with without seizures, unilateral motor deficit, visual disturbances, vertigo, and sensory abnormalities. So you should suspect arterial gas embolism if the diver develop these signs and symptoms within first 10 minutes, especially. So what are the treatment? Always airway breathing circulation important. You have to stabilize the patient. I mean that you do check vital signs. You should keep patient warm and should keep patient neutral position, not pendulum position. Give 100% oxygen by face mask or ED tube. Give IV fluid and hydrate the patient, and then you do a serial neurological examination. If once you get the diagnosis, you should immediately put him in a recompression chamber. This is a recompression chamber we use to treat these patients. It is life-saving. Then the most important thing, how to prevent pulmonary barotrauma. Prevention has centered on standards of fitness for divers and modification of training and diving techniques. Entry-level recreational divers are taught that the most important rule in scuba diving is to breathe normally at all times. Never hold your breath. So the instructors give considerable effort goes into instilling this as a mantra. Also, dangerous diving practices to be avoided when there is no experienced medical staff or full recompression chamber on site, such as skip breathing, body breathing, ditch and recovery training, emergency free ascent, usually should avoid. Then during medical selection, there are some conditions you should see and exclude them from become divers. Previous spontaneous pneumothorax, asthma, sarcoidosis, cysts, tumors, pleural adhesions, intrapulmonary fibrosis, infection, chest wounds. We do not recommend them to become divers. The other asthma, here you should do, it's very contest sensitive. It's actually based on merits. Then diver evaluation. Divers must undergo medical examination or medical test every year. Here, diver evaluation involves performance of respiratory function test, and pre-diving chest X-ray. In most cases, single full-plate chest X-ray is acceptable. In some groups, we ask them to do inspiratory and expiratory chest X-ray to demonstrate any air trapping. If there's high suspicious of gas trapping, more sophisticated lung function test indicated, such as high resolution or spiral CT. That's the end of pulmonary barotrauma. Now I'll quickly go through ear barotrauma. Out of ear barotrauma, middle ear barotrauma is the most common type. So I will here brief about middle ear barotrauma. It's more common in inexperienced divers, actually due to ineffective valsalva. The main reason is blocked ET tube, maybe due to upper respiratory tract infection, or maybe due to large adenoid, tonsils, or nasal septal deviation. What is the pathogenesis? Relative vacuum form in middle ear. Due to ET tube block, there's a vacuum create inside the middle ear, which result capillary leakage. If the pressure difference is more than 100, around 500, tympanic membrane will rupture. So what are the signs and symptoms? Fullness or ear pain, mild transient conductive hearing loss, tympanic membrane perforation in severe cases, or maybe blood in the face mask, transient vertigo or tinnitus. If the diver tell these signs and symptoms, it can be a middle ear barotrauma. So we graded according to the otoscopic finding. You can see it's the grade 0, it's normal. Here you can see mild redness, it's grade 1. The grade 2, when it's becoming grade 4, there's a rupture. You can see blood. And grade 5 is large perforation with blood. Next slide, you can see a footage where diver developed tympanic membrane perforation. Here you can see while he performing valsalva, you can see air coming from his ear. So he developed tympanic membrane perforation due to middle ear barotrauma. So what are the treatment? Decongestion, intranasal steroid. Systemic steroid we recommend if there's a moderate to severe barotrauma. Antibiotic if it is perforated. You should avoid topical ear drops if perforated unless recommended by ENT surgeon. So prevention, equalization is very much important. So what are the equalization techniques can be used? Valsalva, Tourniquets, Frenzel, those are the names. Valsalva you all know. Tourniquets swallowing with closed nostrils. Frenzel mean moving jaw forward with closed lips. So prevention, there are simple rules. I will rush because due to the time limitation. Practice and ensure reliable middle ear auto-inflation on land, only then consider diving. Auto-inflation in the middle ear on the surface immediately before descent. Auto-inflation every 1 meter of descent. Use a decent line. Auto-inflate with the head upright. Do not descend if pressure is felt in your ears about the dive, and do not do multiple ascents or wait at depth to equalize. Do not dive if you have upper respiratory disorders. So those are the simple rules to prevent middle ear barotrauma. It's important to understand this prevention method. So these are the method: Valsalva maneuver, Tourniquets, and Frenzel. Tourniquets swallowing with closed nostril. Frenzel mean moving jaw forward with closed lips. That is the end of my presentation. Thank you. Thank you very much.